I would like to thank the organizers for the privilege of presenting the conclusions of this event. Filled with extraordinary speakers' presentations, which are living proof of successful experiences based on knowledge and on the commitment and responsibility with the social aspects. Diabetes has many aspects that can be intervened. It's a process that starts many years before its diagnosis. This slide shows the populational blanks identified in accordance with the document I will go into detail on later on by the National Academy of Medicine. This document identifies 4 objectives: a favorable environment for a healthy lifestyle, which will benefit not only in the incidence of diabetes, but all chronic diseases. Doubtlessly, this is one of the primary objectives, but it will take much more time to observe the social and economic impact measured by the mortality rate and hospitalizations than the measures I will describe as follows. So the objective is early detection of people at risk that will help us to lower costs and also treatment time and reduction of incidence of diabetes. Not less important is the efficient and timely attention for people who have been diagnosed, where we still have a cost efficiency relation before complications occur. Also important is the coordination of changes proposed on a local, municipality, state and national level to facilitate efficient efforts and avoid wasting resources. As one of the first speakers said, Dr. Hernandez, it's one of the diseases where we know what to do. There are guidelines on a global level, regional ones, local documents, even specific strategies created by the World Health Organization for emerging countries. The dilemma is how to put it into practice. We have to consider and use the material generated as ideas in the presentations we heard today, and we should consider these chronic diseases as a global issue. In accordance with this document, the different interventions can be classified into 3 big groups, but every one of them has to consider the social environment and others Dr. Lee mentioned. However, this is not enough if we want to have an impact in the short term to reduce the incidence. Therefore, it is important to consider in complementary fashion the risk statuses and the development of prognosis tools for each population, because in different ethnicity the incidence is a different one. Every one of these actions has to be based on a conceptual model. Dr. Irwin talked about a model which also includes transport. Regardless of the intervention I showed in the slide before, they have to be based on conceptual modules that measure pre-established outcomes, and this will be the ticket that will allow us to take decisions so that actions can be extrapolated to the entire population. And as an example, I could mention the change of the environment built by the human beings, and Dr. Ewing talked about 5, about diversity, density, distance, design, and access. And this is feasible. Even in Latin America it has happened, as I showed in Bogota, one of the few cities worldwide that complies with the requirements of the recommendation of the World Health Organization about physical activity. 57.8% of adults walk more than 30 minutes per day, and there are measures taken in Mexico. Bicycle roads have been built, and if they are built correctly, where bicycle users does not have contact with cars. and the development of a public transport system which is designed appropriately to consider where the farthest distance and to a train is less than 1 kilometer. We also built public gyms, and this took more than 25 years to show the first results. Dr. Monsafarian spoke about the multiple determinants of food consumption shown on this slide. He explained that these were factors to be considered. I propose them as areas of opportunity. Each one of them could become an intervention model, as in the model pointed out in the former slide, where we can identify concrete objectives we want to change and how we can build win-win relationships to overcome hurdles and turn them into opportunities for a healthier environment. Dr. Monsafarian spoke about the importance of new research in the way to qualify food and how to transmit these messages to the population and change paradigms based on research in humans and also in communities and later on in nations. This slide, which changes the food pyramid for a version which is more focused on the Mediterranean diet. Even if this is a highly controversial aspect, but my message is perhaps that there is no homogeneous message for all of populations. The adjustment of caloric intake and the elements that have been shown harmful for health and replacing them for options that have been proven in observational studies to have benefits for health. Likewise, we have to translate the empowerment message to the population. I think this is one of the areas that should have been emphasized more in this conference. The media and government entities and non-governmental institutions have the responsibility to identify messages that should be transmitted to the population in a clear language to empower them and motivate them to identify their risks in order to take the adequate measures. Let's move, like many other programs in Europe, do have this, but every population should find the message in their culture and in their socio-economic environment. Perhaps one of the most biggest challenges is the change of the lifestyle in schools, and this is feasible. As a matter of fact, via different of our speakers, we were able to look at successful experiences arising from a work done in Guatemala that built a conceptual model and identified who were the potential allies. And in a period of 6 months, they were able to achieve successful results to change the school and community environment. But this does not suffice. It does not suffice to change a lifestyle in schools. More than 10 groups have done so. In the end, it is important to transmit these changes to the community, and therefore all researchers who have become involved in programs of lifestyle changes in communities or schools should create procedural manuals, extrapolation manuals that can be delivered to the decision makers together with the pre-established outcomes, which are the tools and key for these small interventions that benefit one small group become drivers of change on a community level. And this is a positive example which was presented to us about the Baltimore experience. And it's about a program in small communities in low-income supermarkets can be linked, thanks to the measurement of pre-established measures, to a community program and become a public policy. All of this was started by an academic unit without the involvement of the government and through the engagement of their leaders. There's not one intervention applicable for all. We have to identify groups in the population that call for specific actions. And this was mentioned in the presentation of Dr. Rosales and the Mexican counterpart about interventions carried out at the U.S.-Mexican border. We also could speak about marginal areas in Mexico or the southern border of Mexico, areas that due to their features call for specific actions, individualized actions, and many of the actions we saw here might not be applicable for them. In Mexico, we have applied many of what I mentioned before. The action program against obesity was started in the last administration, and a task force was created and commissions to change the food consumption, and there were also specific actions to empower the population and the involvement of the media to avoid exposure of children to unnecessary publicity of junk food, and also actions taken in school, as well as the national strategy to control overweight and diabetes. But if we cannot implement this with people who make decisions, we will not be able to reach the general population. I will end my presentation mentioning the work of the National Medical Academy and the resulting document, which is a catalog of 100 actions identified as cost-efficient and applicable in Mexico. It is clear that there is not one action that can be used for all people at risk in the general population. Therefore, we identified 100 potential actions that could be considered by any user to change his environment, to detect risks, and improve also the services provided to the diabetic population. We used a cross-discipline team consisting of 100 health professionals, sociologists, economists, physicians, in order to generate these recommendations. Later on, a different group of actors validated the 100 actions and prioritized 25 they considered as the most important ones, which are the ones I'm showing here. We identified the 4 goals with which I started my presentations, and a particular emphasis on the second objective, which is the detection of people at risk, and the 4 actions considered prioritary, which is a detection of risks in schools and units of first contact using protocols, which I will mention further on, the empowerment of risk cases with homogeneous actions, and the certification of centers to empower these people, and the screening and management of gestational diabetes. And we need also a register and programmed follow-up to reduce the incidence of diabetes. Here I would like to underline that the document is against the open screening programs. Systematic measurement in open populations should be focused on the timely detection using a stratification of risk based on clinical data or other tools like FinRisk or CanRisk, or tools we have to create in our own population. For those cases identified as at risk, the next step is to measure fasting glucose. If they have 100 per deciliter, we have to empower the person to change a lifestyle and using homogeneous protocols. For those individuals from 100 to 125, the formally measured and pharmacological treatment and confirm the diabetes diagnosis. Doubtlessly, there are many interventions that have been capable to prevent diabetes, and the modification of lifestyle is the one which has the best cost-benefit relationship. However, translating it to a Non-specialized population into an open community is the biggest challenge to make it a cost-efficient intervention. It can also be based on pharmacological treatment, but at a higher cost and potential secondary effects. The prevention of diabetes has shown to be an intervention which is prioritary, and here I show the cost that represents if we do not stop the evolution of diabetes. And even recently diagnosed patients also generate almost the same costs like the people at risk. And this should be also considered a priority to reduce the cost of this disease. In different countries, like in India and others, it has been tried to replicate the DPP study in a much less complex system and using generic drugs. And via the empowerment of patients and health professionals which are not specialists and the use of therapeutical options achieves to considerably reduce the cost of the intervention, and it becomes a highly cost-efficient option. However, this area is still one that calls for more research. Many of the people we call pre-diabetic are not equivalent to the ones included in the investigational studies, which were limited to glucose intolerance. In our countries and many others, there are no integrated screening programs which are structured for high-risk cases. Therefore, this document is against the generalized screening programs. Only those health systems with a structured intervention to reduce chronic diseases are the ones that should generate screening programs. And finally, we have to take into consideration the risk of stigmatization of individuals at their work site or in insurance programs before embarking on these programs. I would like to conclude. Our objectives are three extremes interacting in the center with trained and organized service suppliers. At the upper tip, we have the leadership of work groups who create portfolio strategies of empowerment that have to be translated to the rest of the population. Downwards, informed and proactive communities that educate their peers to call those people's attention that need it to change their lifestyle, and patients and families which are empowered, capable to take charge of their lifestyle. In order to achieve this, ideally, we would use a bottom-downward approach with leadership. Many of the things we saw in this conference have been created based on academic institutions, NGOs, and social organization, meaning that everybody can be a starting point to achieve this virtual triangle. The message is that prevention of diabetes is a priority objective of all national health plans. We need to take individual action and go to joint efforts and translate research in public policies to prevent diabetes is the responsibility of all. Thank you.